Good morning, everyone. If you could take your seats, we will get started in just a moment. Okay, thank you all so much for coming out. It's my great privilege to introduce Governor Dan McKee for some welcoming remarks.
Good morning, and thank you, Cory. It's great to be here. They changed the room around. Used to, I think I was standing up there and speaking that way, but I think it's a reflection. There's probably a bigger crowd in here today, Cory. So that's reflective currently of the work that we're all working together on. So we're certainly committed to continue to improve the quality of and access and equity and affordability of healthcare, and I think that's what we're all here for today, to continue that effort. And I'm grateful that so many talented and experienced professionals on our team are here working together. They bring decades of experience in government and healthcare industry, and I'm pleased to be able to meet with them on an ongoing basis to come up with the ideas of how do we continue to deliver healthcare in a way. And I always go to let people know that one of the things that Rhode Island does very well is healthcare. When you take a look at the national rankings, we're in the top 5 in the country, and there's a reason for that. And the reason for that is many people are sitting in the room today. In the fiscal year 23, we funded a health spending accountability and transparency program so we could measure and track our performance. The data informs our work with doctors, hospitals, consumers, employers, insurers, so together we can make improvements. This year we issued an executive order. I think Secretary Charest is around here somewhere. You're in the back row with like Bob Uecker back there. Looking good. We established an executive order establishing the healthcare system cabinet so my administration can take a unified, independent, interdepartmental approach to evaluating and proposing recommendations about quality, affordability, and equity across the continuum care. Like many states, Rhode Island's healthcare systems is challenged by workforce shortages and disparities in access, quality, and outcomes. This planning effort will align closely with the private sector community, partners, and healthcare consumers throughout the process, and we're very pleased that we have such an active group that is working on it. So Secretary Charest, thank you for helping coordinate that, and I know that we've meeting regularly with updating on how that process goes. In addition to the work of the cabinet, my administration has made significant investments in healthcare system throughout Medicaid, with plans to increase rates for community provides in home health, behavioral health, and early intervention. We also placed a state-directed payment program for hospitals that will drive over $100 million in new Medicaid funding in this current fiscal year. I also want to really give a shout out to DHS for those who were involved with the issues that have to do with Medicaid, in terms of 370,000 people that needed to get either stayed on the Medicaid or not, and what a great effort there. And I think that it's continually working in this space that generates the professionalism that we have. But that alone, I think you're going to hear, is going to have a significant impact on our budget. And as we continue to work on budget issues, these are the things that help us deliver on the services that we need to provide. So that's a shout out to Kim Barad and her team. I know that the commissioner has some very positive news to share with you about ways Rhode Island is keeping costs in check to everyone's benefit. So I'm happy to turn this mic back over to Cory. Cory King, come on up. Thank you so much for your work as well. Thank you all for being here today.
Okay, Thank you all so much. So we have a very exciting agenda for today's public forum. I want to start with some thank yous. Governor McKee, thank you for your support for this program. It would not exist if you had not requested appropriations in your budget 2 years ago. So thank you for that, and thank you to members of the General Assembly for funding this work. I want to especially send my thank you to the Executive Office of Health and Human Services. So about a decade ago, the state created an all-payer claims database, and EUHHS has led the development of that into a shared analytic resource across state agencies. Much of the work that we're going to present to you today would not be possible without that. So Secretary Sharist is in the room, other members from EUHHS, so thank you for that. And I also want to thank the Cost Trend Steering Committee, my co-chairs Michelle Letterberg, Dr. Ed McGuckin, and all the members of the steering committee who are here today, and members of the public. In addition to today's presentations, we have an annual report and a new chart book. Both are on the OHIC website currently, and we'll be sending out a constant contact notification later today with links to those reports. The first item on our agenda is a review of the performance against the state's cost growth benchmark, as well as some data on healthcare quality performance and some new health equity measures. And then we'll conclude today's public forum with a presentation from state leadership from Massachusetts, Connecticut, and here in Rhode Island on efforts we're all undertaking to improve affordability and healthcare system performance. This is an opportunity to ask questions. During the first presentation, if you have technical clarifying questions, we welcome those during the presentation. If there are broader discussion questions, bigger picture questions, please hold those to the end. And so with that, I'd like to introduce Michael Baylett from Baylett Health Purchasing to lead us through the first part of our agenda.
Good morning, everyone. Okay, so Cory just reviewed this a little bit, but this is the agenda specifically for what I'm going to share with you. I'm going to give you a little bit of background on Rhode Island's cost growth target, and then I'm going to share performance data for you at multiple levels. And then I'm going to share some targeted analyses of what's been driving spending using data from the all-payer claims database. Rhode Island has some fabulous tools to do so. Then we are going to share for the first time parallel information on quality performance at the insurer level and at the ACO level, and then some baseline performance on new public health and health equity measures that were adopted this past year. All right, so first a little bit of a background. For those of you not aware, the state created the Cost Trend Steering Committee in the summer of 2018, and it set out specifically to adopt strategies to slow healthcare spending growth through the use of a cost growth target. The committee established a target initially for 4 years at 3.2%, which represented at the time projections for state economic growth. That target extended through 2022. So in 2023, the steering committee selected a new set of targets extending through 2027. These were memorialized in a voluntary compact signed by the same organizations that signed the initial compact. And the new target considers both state economic growth and median household income growth. So the latter was an addition or a refinement to the initial methodology and was intended to reflect consumer impact of healthcare spending growth. Rhode Island is now one of 8 states across the country that have cost growth targets, and Rhode Island was, following Massachusetts' lead, a pioneer in this movement. So when we measure spending against a cost growth target, exactly what are we measuring? We are measuring total medical expense. This is all incurred expenses by Rhode Island residents, regardless of where they receive services. It includes both payments to providers as well as the patient's spending obligation for deductibles, coinsurance, copayments. It also is specifically just for covered services. 2, it includes what we call the net cost of private health insurance, which is administrative expenses and margin that are generated by private insurers. So the first category, total medical expense, we use the acronym TME. plus the net cost of private health insurance equals total healthcare expenditures. And when we measure spending at the state level, we are measuring total healthcare expenditures. But we don't only measure at the state level. In fact, we measure at 4 different levels. So we measure at the state level. We also measure spending growth at the market level. And here we categorize spending primarily into 3 markets: commercial, Medicaid, and Medicare. We measure spending at the payer level, and that's by insurers, but we do so by market. And then finally, we measured at the provider organization level. So that's accountable care organizations, this is our unit of measurement, or for the Medicaid program, accountable entities. And for all of these provider organizations, we are also measuring performance for each of the 3 markets: commercial, Medicare, and Medicaid. Okay, so just a little bit of context about what we are measuring. This year, for the first time, as I noted, we are also measuring performance for public health and health equity. So the Cost Trend Steering Committee last year convened a work group to develop a set of public health and health equity targets, and that was done with the intention that there would be public reporting. Today, we're going to report baseline spending for public health and health equity. We'll be doing so for 6 measures across 4 domains. The first year of performance against these new targets will be 2025, so this is just baseline that we'll be sharing today. Okay, so before I share actual performance data, just a couple of notes. The presentation that I'm going to give today will include data both collected from payers in terms of, or in the form of aggregate spending for the cost growth target, as well as data that comes from the All Payer Claims database. Those 2 sources are not identical. So I just want to draw this out because when we look at analyses using the 2 different data sources, they will not exactly reconcile. And the reason for that is the All Payer Claims database does not have non-claims-based payments. It does not have spending for a lot of the self-insured population, and it doesn't have pharmacy rebates. So those are some differences between the data sets. That being said, according to OHIC's analysis, the All Payer Claims database represents about 80% of total commercial spending in the state. And it's got all of Medicaid and Medicare. Okay, so with all of that as context, I want to share with you now performance in 2022 against the cost growth target. And the story is good. Rhode Island met its cost growth target in 2022. Spending growth, this is for total healthcare expenditures, was 1.6%, so that's below the target of 3.2%. You can see performance for the 4 years for which we now have data. We have this strange COVID-induced blip in 2020 and 2021, but what's notable is that for 3 out of the last 4 years, spending growth was either at the cost growth target or below. I will say this is superior performance to many other states. Delaware right now is considering some legislation specifically because they have blown through their cost growth target every single year. That has not been the case in Rhode Island, and we should all feel good about that. If we look at the breakdown of spending by market in 2022, there's about $9 billion of healthcare spending in the state. The amounts spent on Medicare and Medicaid were actually exactly the same, and spending on in the commercial market a little bit less. Now this is aggregate spending here. You can see those percentage figures. Perhaps you can see them. The numbers are small. But know that this is not per capita. These are gross figures. You can see that spending in gross dollars grew highest for Medicaid. It actually declined for insurer, admin, and profit this particular year. This is 1 year, and we always have to realize 1 year is 1 year, but this is what happened in 2022. Now, if we look at spending by the 3 markets, commercial, Medicare, and Medicaid, we see different trends. And this spending information that I'm going to share is total medical expense, meaning it does not include insurer profit and margin. So what we see by market is that in the commercial market, spending was just slightly above the cost growth target at 3.3%. It was below for Medicaid, 3.1, and lowest for Medicare, 1.8. 3.3% is technically above the cost growth target, but that's awfully good relative to what other states are seeing in their commercial market. And I would say that it's a win for Rhode Island, even though technically it's 0.1% above. Now you'll note here that the per capita spending is highly variable across the three markets, that Medicare per capita spending is about twice what it is for Medicaid and commercial. And that means that whatever the trend is for Medicare is going to have a disproportionate effect on statewide trend. I'm going to focus just for a minute on the net cost of private health insurance. Again, this is insurer, commercial insurer, or private insurer, I should say, administrative expense, and profit margin. This tends to be a pretty volatile measure. It will bounce up and down from year to year. For 2022, it went down. And so that means that it had an overall downward effect on statewide trend, because it is one element of total health care expenditures. On a per capita basis, it was down 5% in 2022. There were some mixed trends for Medicare and for Medicaid. It was growing. For commercial, it was about flat, and for net cost of private health insurance, it went down. But overall, decline of about $22 million. If we look at it by market segment, we can see that there was a big increase for the small group market, so profit and admin up, but for Medicare managed care, it was down 35%, and for the small but very expensive dual eligible program, it was down a whopping 100%. So fair amount of volatility. And again, we've seen this in prior years, that there's volatility in this measure and by market. All right, next I want to share with you what did we observe in terms of trends by service category. And I'm going to share with you trends in spending by service category. This gives us some feel for what was driving spending either up or down in 2022. I'm going to share it first at the state level and then by individual insurance market. So this bubble chart gives us a sense of what happened in 2022. You'll see on the y-axis the rate of growth, and on the x-axis per capita spending. The size of the bubble indicates the overall impact on spending growth. So the first story I want to call out is the biggest bubble is hospital inpatient, and it had negative trend in 2022. Okay, that's quite notable because it's a large category of spending, and it declined at a state level. Again, this is across all three markets. Where was spending growth high? It was high in non-claims-based spending. This is primarily performance incentive payments to providers, and also there was some growth in capitation or capitated payment in the state that year. Other professional grew at 7.1%. That is largely behavioral health spending. We've seen very high growth in behavioral health spending over the last handful of years, especially beginning in 2020 when COVID hit. Spending was also above the cost growth target for long-term care, hospital outpatient, retail pharmacy. Now, when I share it with you at the individual market level, the story is a little bit different in each market. But total overall for the state, these were the trends. The commercial market looks different. So in the commercial market, this is where most of the non-claim spending growth was. There's a whopping 73%. So lots of performance incentive payments to provider organizations, or a lot of growth in it in 2022. I also want to call out other professional. Again, that's primarily behavioral health, 10.5% growth. on a per capita basis, very high growth. And finally, retail pharmacy. Retail pharmacy is the big bubble here at 6.3%. We have seen retail pharmacy with very high per capita spending growth every year that we've been doing this measurement. You can see on the negative side, hospital inpatient at minus 6.6%. So the decline in hospital inpatient spending offset growth in other service categories at the state level, but also at the individual market level. And if there had not been a decline in hospital inpatient spending, we certainly would have exceeded the cost growth target this year. In the Medicare market, a hospital inpatient, again, negative. Big growth, though, in hospital outpatient spending, almost 10% per capita growth in hospital outpatient spending. Also, high growth in non-claims and in other professional spending, and a little more modest in retail pharmacy. And then finally, for Medicaid, the big story here is long-term care spending grew in Medicaid in 2022 at a significant amount, after I think having been flat or negative in prior years. So that was the largest impact on spending growth, but I'll draw your attention to retail pharmacy, also high. Retail pharmacy is the one service category that is consistently high in all three markets year after year, 8.7% for Medicaid in 2022. And here again, hospital inpatient, a negative trend. So a few takeaways from this analysis. Statewide growth was well below the state's target of 3.2%. While this is good news that we met the target, I want to note that we might expect to see spending increase the next couple of years, and that's largely because there's a delayed ripple effect from inflation, which did not hit prices in healthcare in 2022. But that rippling of inflation we can anticipate is going to hit prices and spending in 23 and 24. Two, at the state level, hospital outpatient drove spending growth in 2022, and other professional, again, which is primarily behavioral health, was a much more significant cost driver than we have seen in other years. And retail pharmacy, a continued threat to healthcare affordability. Growth in this category far exceeded the cost growth target in every one of the markets at 6.3%, 4.3%, and 8.7% across the three markets. Okay, I'm going to pivot now to talking about performance at the insurer level. And again, I'm going to do this by market. So I'm going to start with commercial insurance. And the data that's presented here is presented in confidence intervals. So the confidence intervals are the horizontal lines. The dot in the middle represents the measured rate, but the horizontal line's width is the range estimate for where we can be 95% confident that the actual performance lies. And we're measuring that against the red vertical dotted line because that represents the 3.2%. And when the horizontal line is completely to one side, then we can say with full confidence that we think that the organization either met the target, in this case if it's on the left, or if it's completely to the right of the red vertical line, that it exceeded the target. So in this case, 3 of the 4 commercial insurers met the target. Blue Cross Blue Shield at 3.9% was above the target for one this year. I want to note that when we measure spending at the insurer level and at the ACO or AE level, we are making a couple of adjustments. One is we are adjusting for high-cost outliers. So to the extent that an insurer or a provider organization had individuals with extremely high spending, we are removing the very high spending above a certain level. We're not counting it because those very high cases occur randomly, and we know that a particular year of having more or fewer high-cost outliers will have a significant impact on trend. So to to smooth out the distorting impact of the high-cost outliers, we apply something called truncation. The other modification we make is we adjust for the age-sex composition of the population, and specifically whether an insurer's population or a provider organization's population became younger or older in a given year. And if it did, we're accounting for that because we don't want to penalize an organization because the composition of its population changed in a way that would result in either higher or lower spending growth. So this is commercial insurer performance for the Medicare Advantage market. Blue Cross Blue Shield met the target. We cannot make a determination for United Healthcare because you can see that its confidence interval crosses the line. And finally, for Medicaid, all three of the plans met the cost growth target. The last market is Medicare, Medicaid. There's just one plan. Neighborhood Health Plan has a product here. We've witnessed that spending here is extremely volatile. The population is small and extremely expensive. In this particular year, spending exceeded the cost growth target primarily because of growth in home health spending and in hospital outpatient spending. Next, I'm going to share provider performance against the cost growth target. I want to note that when we measure ACO performance against the cost growth target, the trends are always higher than they are at the insurer level, and there's a reason for this. Primarily, especially in the commercial market. In the commercial market, the way that we measure performance against the target is by attributing members to provider organizations. Or I should say, this is what the payers do. The payers attribute individual members to provider organizations, and they do so by looking to see at which provider organization did members seek care. We don't do that for the insured population. What's the difference? Well, in the insured population, there is a subset of people who do not access any services during the year. We'll call them non-users. When we measure spending for provider organizations, there are no non-users because of how we attribute spending. So because they have no non-users, the spending is higher, and the spending growth may be higher as well. So I want to explain why you're going to see higher trends for the ACOs and for the AE, well, especially for the ACOs, because of this attribution. So for 2022, the ACOs, or 3 out of the 4, did not meet the target. You can see their trend rates. The ones that exceeded were between 5 and almost 7%, so fairly high growth for 2022. We can't make a determination about Coastal Medical's performance with full confidence because its confidence interval crosses the cost growth target line here. Now, there are more ACOs in the state than just these 4, but these 4 met our threshold for public reporting by having enough covered lives. So some of the others, particularly the FQHC-based ACOs that serve smaller numbers of commercial populations, were not included here because they didn't meet the attributed lives threshold. In the Medicare market, performance was mixed. So 2 of the ACOs, Integra and Lifespan, met the target. We could not make a determination for Coastal, and Prospect Charter Care exceeded it. And then finally, in the Medicaid AE market, we can see that most of the AEs met the benchmark. There were 2 for which we could not make a determination. So the trend rates are quite variable when we look at them at the market level for ACOs and AEs. And clearly much lower for Medicaid than for the commercial market. Okay, so I'm going to pivot now away from the cost growth target data to share with you some analyses from the All Payer Claims database, which gives us a much finer understanding about why some of these trends occurred. So the cost growth target data certainly called out hospital outpatient spending growth and retail pharmacy as primary drivers of spending growth in the commercial market. But the cost growth target data don't tell us exactly why these trends occurred. We can't answer the question of why hospital outpatient spending went up or retail pharmacy spending went up, or why hospital inpatient spending went down. And so we have to use the claim level data in the all-payer claims database to give us this insight. And I will note that last year at this meeting, we announced that OHIC was making some of its tools, which we refer to as dashboards, available to the public. Those are still on the OHIC website and the OHIC Data Hub. And in fact, there are now additional dashboards on that website added just last week. So these dashboards, and you can see a few of them here on the left, allow users to examine per member per month spending, as well as to look at trends in unit payments and in utilization. You can also filter the spending by age and gender. There are also some dashboard views that allow you to look at spending by geography and spending growth by geography within the state. So OHIC used these tools to examine contributors to spending growth in the commercial market in 2022. I'm going to share the results of these analyses. As a reminder, the data source is different than for the cost growth target, so the numbers never completely align. So on the OHIC Data Hub, one of the dashboards is a cost trends overview that allows us to look at spending growth between 2018 and 2022 on a per capita basis by market and by service category. So we can see here per member per month spending, payment levels and trend in terms of payment per unit and in units per 1,000 members over the 5-year period. If we focus on hospital outpatient and retail pharmacy, we can see that it was increases in payments per service unit that drove spending growth in 2022. Hospital outpatient payment per service unit grew nearly 8%, while utilization actually decreased 2%. And for retail pharmacy, payment per unit grew 12% in 1 year, while utilization of retail pharmacy drugs increased just 1%. So the problem is the payment levels, or at least for these two categories, it was not service utilization growing. So if we look specifically at retail pharmacy, we can see that growth in unit payments has been going on for several years. This was not just a 2022 event. In this graph here, you can see over a 5-year period, retail pharmacy unit payments grew over 20%. That's an average of over 5% a year. That's way above what median household income was growing in Rhode Island during this time period. So this has been a persistent problem. Now, utilization has not been flat. It's grown, but it's grown at a much lower rate than has payments per service unit. The problem here is really twofold. It's both an increase in prices. It's also the introduction of very expensive new drugs into the market. Okay, and I want to note this is just retail pharmacy. We are not here measuring what we sometimes refer to as medical pharmacy or physician-administered drugs. That is another source of very significant spending, but it's not counted as retail pharmacy. That shows up in hospital spending and in professional spending. I think we went into some detail on pharmacy spending at last year's public meeting. We're not doing that this year. We're going to focus on some other areas, but we share this information just to make clear that the problem of spending growth, especially price growth in pharmacy, is a persistent one and a threat to affordability in Rhode Island. Okay, so I'm going to pivot now to talking about the trends we saw in hospital spending, both the decline in inpatient and what happened in outpatient. So for inpatient hospital, what we witnessed here was a decrease in payment per service unit. Now, this is highly unusual because we know that the prices paid by commercial insurers to hospitals do not decline over the course of a year. And so we dug into the claim data using our interactive dashboards to understand why did payment per service unit decline in 2022? And we found that there are three factors that resulted in a decline each of the last 3 years. And I'm going to review these three factors on the following slides. So driver number one was a major shift in location of joint replacement surgery from the inpatient to the outpatient setting. So in 2020, you can see for both hip and knee replacements that the location of site of service was fairly close. There's a huge divide that's happened since then, where almost all joint replacement surgery in 2022 was taking place in an outpatient setting. Just a dramatic change over a very short time period. And this was due to both technological advancements in surgery and also some federal changes in Medicare rules. Why does this shift in location matter? It matters because the prices paid are much lower in an outpatient setting than in an inpatient setting. Okay, so these fairly expensive inpatient procedures are moving to an outpatient setting, and that means there's going to be a downward pressure on the average payment per inpatient unit because these inpatient procedures that are about $33,000 a shot, they're disappearing. Okay, so that's reason number one. Reason number two, big decreases in cases of major respiratory infection and inflammation. This is obviously a result of a decline in hospitalizations for COVID-19. And you can see a dramatic drop-off in spending for major respiratory infections between 21 and 22. We also had a big drop in respiratory support with the use of ventilators, also likely due to a drop in COVID-related admissions. And then our third reason why there appears to have been a drop in inpatient hospital prices is there was a big drop in utilization of two different types of high-cost services, organ transplants and tracheostomies. And these graphs, again, show the decrease. These are not high-volume services, but the price paid is in excess of $200,000 per admission. So they're very expensive admissions. The drop in tracheostomies is probably, again, related to the drop in COVID admissions. The drop in organ transplants, I'm not sure of the reason for this. I don't know if this is a random variation or if there's something systemic that happened. So, in summary, increases in unit payments were the reason for spending growth in hospital, outpatient, and retail pharmacy in 2022. And there are multiple reasons for the decrease in inpatient hospital payments per service unit, really in the last 2 years, 21 and 22. So this is an example of how OHIC can use now very sophisticated tools that I would say exceed what almost any state has available to them to identify not only where is spending growing or declining, but also why it's spending and why it's declining. And with that information, we are better informed to be able to target interventions to either improve access or slow spending growth, as the case may be. As I noted earlier, there are now new dashboards available on OHIC's Data Hub. They are listed here. Two of them look at migration out of the state for services, one for outpatient chemotherapy and one for inpatient admissions. There is a dashboard on chronic conditions, one on emergency department visits stratified by severity, and one looking at inpatient trend by diagnosis-related group. You are all encouraged to access these dashboards. They will tell you everything that we needed to tell the story that I just told you about what happened with inpatient and outpatient payments over the last year. All right, so I am going to invite my colleague. Yeah, go ahead, Howard. I'm sorry, what number, Howard? 14. This is insurer, administrative, spending, and margin. Okay.
So we're saying, so for example, just if I look at that in the column that says 634 million, self-insured at 138 million in administrative spending.
Right.
Where does that come from?
All this information is reported by the insurers. Okay? This is insurer, not employer. This is insurer, administrative, spending, and margin.
Right, you just said self-insurance. So that's what they're spending on
To administer the plans.
self-insured plans.
Yes. Andy?
You showed data that was the level of growth across the different commercial insurers in the state. And I was curious if you happen to know the approximate mix of self-insured versus full insured business in those plans, and how that might contribute to the variation in the growth rates.
Can you ask your question again? I'm not quite sure I followed you.
All right, so these commercial insurers would have some fully insured business and some self-insured business.
Yep.
And there was variation in the cost growth across these commercial insurers. And my question is,
Oh, how the trend varied for insured and fully insured
that's right.
and self-insured? Yeah, I don't have the information for you on how the trend varied for self-insured and fully insured.
Do you happen to know, like, Blue Cross had the highest, they were the only carrier that had above target growth. Do they have, I believe they have the highest self-insured business. Do you happen to just know approximately the number? All right, sounds good.
No, sorry. Sam?
Hi, Michael. Thank you for this great presentation. On slides 17 through 20, we show a large growth in non-claims expenses that you mentioned. And I wonder if you have any insight into sort of what types of institutions and services that non-claim spending is going to support. And follow-up question, if this is a growing category of spending, should we think about breaking it out in a different way? Because non-claims is pretty general and it can go into lots of different sorts of...
Yeah. So we do collect it in subcategories. We report it in aggregate. For this particular year, it was primarily performance incentive payments, which is probably primarily the result of ACOs performing well in shared risk arrangements and earning distributions. This is by far the highest we've ever seen. I would expect that this measure too is going to be a little bit volatile from year to year depending upon how organizations perform against their contractual targets, and this was clearly a year where they did really well. But we do have the ability, Sam, to report at a more nuanced level. Okay, so I want to pivot now to sharing with you statewide and market level quality performance information, and my colleague Grace will share this information with you.
Thanks, Michael. Hi, everyone. I'm Grace Flaherty from Baylett Health. Like Michael said, we're going to move on to the quality portion of today's presentation. I will be speaking to quality performance on two different measure sets. The first is focused on traditional healthcare quality measures, and the second is those public health and health equity measures that we're reporting out on for the first time. I'll start with the healthcare quality measures. This is the second year that OHIC has reported out on performance for the core measures in its ACO measure set. OHIC has chosen to report out on these core measures because they are required for use by commercial plans and they are one of a broader set of measures that are in OHIC's aligned measure sets. I'll be sharing commercial and Medicaid performance on the ACO measure set and for performance year 2022. I'll only be sharing market level performance. However, the report that's now posted on OHIC's webpage has more granular performance, including at the insurer and ACO and AE levels. There were 8 or 7 measures in the ACO core measure set for 2022. They cover chronic illness, behavioral health, and preventative care. These measures include breast cancer screening, colorectal cancer screening, eye exam for patients with diabetes, follow-up after hospitalization for mental illness, HbA1c control for patients with diabetes, the adolescent age range for child and adolescent well care visits, and developmental screening in the first 3 years of life. A couple methodological notes before I share 2022 performance. The commercial data I'll be sharing today were collected directly from insurers. The commercial performance is a weighted average of insurer performance because for the commercial market, multiple insurers submitted population samples rather than for the full population. The Medicaid data I'll be sharing today are from EOHHS, which collects performance on the ACO core measure set as part of its AE common measure slate. Medicaid voluntarily aligns with OHIC's aligned measure sets. The Medicaid data represents the full population for these measures because that is how EOHHS collects it. On this slide, you can see statewide commercial performance on the ACO core measure set for 2022. We've compared performance to national commercial percentiles, the 90th percentile and the 75th percentile. You'll notice for child and adolescent well care visits, we don't have percentiles to share because of how they're reported out. In 2022, Rhode Island performed above the 75th percentile for all measures and above the 90th percentile for all but one measure, HbA1c control. Rhode Island performed best for breast cancer screening and developmental screening in the first 3 years of life and has the most opportunity for improvement on follow-up after hospitalization for mental illness. For Medicaid performance, we do not have performance to share for colorectal cancer screening because it wasn't in the 2022 AE common measure slate. Medicaid performance overall was a bit lower than commercial performance and not as great compared to national percentiles. However, I'll note for many, but not all measures, the Medicaid national percentiles are higher than for the commercial market. Rhode Island was above the national 75th percentile for all measures except one and was above the 90th percentile for 3 measures. Medicaid performed best for developmental screening and has the most opportunity for improvement for follow-up after hospitalization for mental illness, similar to the commercial market. As I noted, overall performance rates were higher for the commercial market than the Medicaid market for the ACO core measure set. The biggest disparity in performance was for breast cancer screening and for child and adolescent well care visits. However, as you all know, there are significant differences in the populations for both markets. Yes, please.
Is it adjusted for those differences? Is the data adjusted?
There's no demographic or clinical risk adjustment for the quality performance. Mhm. Any other clarifying questions before I move on? Okay. Moving on to our baseline performance for the new public health and health equity measure set. The Rhode Island Cost Trend Steering Committee recommended that OHIC select a new set of public health and health equity measures to complement the cost growth target or the focus on cost growth in the state. So last year, OHIC convened a work group to recommend measures and associated targets. The work group met over the course of the year and ultimately recommended 6 measures, each with either a total population target or a target focused on reducing a significant inequity in performance. and all of which have targets for 2027. The Cost Trend Steering Committee adopted these recommendations late last year, and today I'll be sharing the baseline performance for all 6 measures, and then OHIC will continue to report on these annually until 2027 performance is reported. The 6 measures in the measure set cover 4 domains: childhood obesity, behavioral health, healthcare access, and maternal and infant health. I'll run through these measures and their data sources quickly. The first measure is adults without a usual source of care. That is sourced from the Behavioral Health Risk Factor Surveillance System, or BRFSS. The second measure is the childhood obesity rate, and that is calculated using BMI clinical and billing records, calculated and analyzed by Rhode Island Kids Count. The third measure is fatal overdoses, which is sourced from the CDC State Unintentional Drug Overdose Reporting System. The last 3 measures are focused on maternal and infant health, inadequate prenatal care, the infant mortality rate, and severe maternal morbidity, all of which are calculated using data from Rhode, the Department of Health. This slide shows baseline performance and the 2027 targets for each of the 6 measures. Adults without a usual source of care has a target specific to the Hispanic population because that was the group that the work group identified the most significant disparity for. Baseline performance for 2022 was 24% of Hispanic adults without a usual source of care, which is a significant inequity when you look at statewide performance of 11.4%. And the 2027 target for this measure is less than 17%. For childhood obesity rate, we have separate targets for Black and Hispanic children because of the disparities the work group identified on this topic. Baseline performance, and this is for 2021 for childhood obesity, was 29% for Black children and 33% for Hispanic children, compared to 23% for children statewide. And the 2027 target for these 2 populations is 23%, or less than 23%, and less than 27% for Black and Hispanic children. The fatal overdose measure has a total or statewide population target. Baseline performance for 2022 was 39.8 deaths per 100,000 persons, compared to 35 deaths per 100,000 persons nationally. And the 2027 target is a goal of reducing these deaths to less than 35 per 100,000 persons by 2027. Inadequate prenatal care, or I should say for the last 3 maternal and infant health measures, these are targets that are measured using 5 years of data. So this baseline performance represents 2018 to 2022. And this larger year range was recommended because of the volatility in these measures in small populations. Inadequate prenatal care has a target specific to the population less than 20 years. Baseline performance for this population was 8.1% with inadequate prenatal care compared to 3.3% statewide. And the 2027 target for this population is having an inadequate prenatal care rate of less than 4%. For infant mortality, there is a combined target for the Black and Hispanic infant mortality rate. Baseline performance for this measure is 7.7 deaths per 1,000 live births, which is 2.2 deaths higher than the 5.5 statewide rate. And the 2027 target for this measure is less than 5.5 deaths per 1,000 live births. And finally, severe maternal morbidity has a total population target and hopefully to reduce severe maternal morbidity from what we're seeing at baseline of 86.2 per 10,000 delivery hospitalizations categorized as severe maternal morbidity. And the 2027 target for severe maternal morbidity is less than 75 per 10,000 delivery hospitalizations. So obviously lots of room for improvement for all 6 of these measures, and we're planning to report annually on our progress towards all 6 of these 2027 targets. One final note on this public health and health equity measure set. In order to make progress towards meeting these targets, OHIC is convening a public health and health equity strategies work group that will be meeting this year. The work group will be recommending to OHIC at least one actionable strategy to meet each 6 performance targets adopted by the steering committee no later than mid-December of this year, with the intention that these performance or these strategies could be implemented in 2025. So hoping to make actionable progress towards meeting these goals. Thank you very much. I think unless there's any questions, I'll pass it back to Cory.
All right, thank you, Grace and Michael, for that excellent presentation. So we're going to open it up to general discussion questions. Maybe Michael, Grace, the 3 of us could sit at the table up here, or 2 of you there and me here. Please use your stage voice so we can try to pick up the audio, but I will kind of rephrase people's questions. Sam, before we get into the Q&A, I did want to note, you asked a question about non-claims payments. If you look at the new chart book, we have some very detailed information on the specific categories within non-claims for the commercial market. So the chart book is a new data resource for us this year, so I encourage you all to take a look at that. But looking for questions. Elena.
Because the retail pharmacy does not include rebates, should we be thinking about that a little bit differently, or do the conclusions still remain?
That's a great question. So we have analyzed trends accounting for rebates, and the trends are high after you account for rebates. Now, rebates most year do reduce trends, but we've looked at this on a longitudinal basis, and the spending growth for retail pharmacy is still too high, even with rebates.
Any other questions? I see Sam, and then we'll come back over here.
Thank you. You told a great story about price per unit and inpatient average price per unit changing because the service mix was changing and certain high-cost things that weren't happening when moving outpatient. You could probably tell a similar story about price per unit changing outpatient. Potentially even those exact same joint replacements, for example, moving outpatient might have raised the average price per unit. I like thinking about price per unit separate from utilization, as you know, because the policy measures we would implement if price per unit is more challenging, a lot different than its utilization. I wonder if we should be, or can be, or might be able to measure price per unit of like-for-like services, and if that might be a more important measure for policymakers to follow. Does that make sense?
Yeah, so one way to do that is through market baskets, Sam, where we bring together a bunch of services and we track them over time, holding constant for utilization, which is something that we've been looking at.
And Sam, another plug for the chart book. Again, I'm really proud to have stolen this idea from the Center for Health Information and Analysis in Massachusetts. But the presentation includes a breakdown of various categories of outpatient facility services, and you can see payment per unit, cumulative trends, as well as PMPM and utilization. For emergency department services, we see an increase in payment per unit over time, and there's a specific slide in the chart book which shows you an increasing coding intensity, so the highest intensity ED services, and that's a very good depiction of this sort of change in the mix of services driving a payment per unit calculation. See, Teresa?
My question is kind of broad. It's about the measure regarding 7-day follow-up after hospitalization of behavioral health services. And specifically, how is that measured? And what we could surmise or guess that the lack of providers in the community is a critical issue. But are there any other contributing factors? Are there any challenges to measurement, particularly the growth of telehealth and those items? Just a question about the measurement standard and if there's anything other than the obvious one, a lack of providers in the community that you might have seen.
Sure, that's a good call out. I think there are a couple different things that can impact the performance rate on follow-up after hospitalization for mental illness. I think as you may have noticed, it's the 7-day rate that we reported out on. There's also a 30-day rate for this measure. Behavioral health access and ability or availability of providers to refer out to within 7 days is a challenge. I think also how quickly or the ability of providers to be notified of their admissions or discharges is also a consideration with this measure. So I know that Rhode Island performance on the 30-day version of this measure is a bit higher. So I think those are both good call-outs. Anything you'd add, Michael?
Al Charbonneau?
So, Chris Whaley, Andrew Ryan's colleague from Vermont, Public Health, is in Indiana right now today for a simultaneous meeting where they're rolling out Rhythm 5.0. And associated with that, the Indiana Business Group has a program called Sage Transparency. Don't ask me why they call it that, but it's a bunch of quality measures for hospitals and for healthcare in general. And I'm just wondering if we're planning on expanding the number of quality measures that we currently track.
That's an excellent question. So Mr. Charbonneau asked if we were planning on expanding the number of quality measures that we track. Presently, we have paired the quality measures to the accountable care organizations, which are the units that the provider units that we're analyzing. I will give you a little bit of insight into what we're doing back at the shop. We are taking a look at hospital quality measures, not only within Rhode Island, but within more of a regional context, just to see the data. And this is a question I'd love to pose to the Cost Trend Steering Committee when we next meet. So we've tried to achieve some balance with having a cost growth benchmark, managing spending, but also ensuring that we have quality health care and equitable health care. So if we should expand the set of quality measures beyond the accountable care organization concept, I think that's a discussion we should have. And Sage Transparency is an excellent resource. Yep. Martha.
Given pharmacy is a big driver, do you plan to do more of a deep dive next year, and would that also include a breakout of specialty pharmacy, which has been an even larger driver of cost growth over the last 5 years?
Yeah, so we've delved into pharmacy in the past, including medical pharmacy, because really to look at the totality of spending, you need to look at retail pharmacy and what we call medical pharmacy or physician administered. And in fact, we've got some new analytic tools that are going to allow us to look at them combined. Right now on the OHIC Data Hub, there are separate dashboards for the two of them. When we have looked at them in the past, the story is really all about payment per unit for brand name drugs. It's not utilization by and large, although there are some years where utilization goes up, but basically utilization's flat for pharmacy utilization. And it's not generic drugs where prices are flat or declining. And frankly, which represent most drug utilization, it's all brand name and specialty drugs and the price points.
Yeah, I guess my question was, will you do it for the 2023 data? I get you've done it in the past. I'm just looking ahead and also thinking ahead to 2025 when the IRA impacts will start to be.
Yeah,
might see shifts.
I mean, I think we need to look at it on a continual basis, and this should be an ongoing source of policy discussion.
I think that would be an excellent question for some health services researchers to answer. I don't know what time frame, Ira, should the data play out?
I would just say there's a lag. No, I'm just serious. Clinically, it's going to take a while
Yep.
for the positive impacts of those drugs probably to play out in a state like Rhode Island.
Well, there's only 27% adherence after a year, so it's hard to know what we see.
But I was extolling the tools that Rhode Island has at its disposal. That's beyond what we can analyze.
Yeah. I guess in recent years, an analog to that would be Sovaldi, very expensive drug, deals with hepatitis C, which obviously would cure a number of long-run, more expensive issues. So that's, I mean, it's a good question, but one that the researchers at Brown will have to answer. Okay. Any other questions? I see a hand over here.
For pharmacy, you chose to do the analysis at the service unit level as opposed to something like day supply. Why is that?
Well, so we define the service unit as 30 days supply. Yeah. Thanks for asking.
I saw a hand going up in the back over here. Yes, follow up or different question? Quality experts?
I'll note that we have several screening, depression and behavioral health screening measures in OHIC's aligned measure sets. However, to my knowledge, there are very limited outcome measures that target the outcomes of behavioral health screening that I know of, or at least valid national measures.
Well, there are. So there are depression outcome measures, and they have been, and they're not new, they've been exceedingly difficult to implement.
Yeah.
For a number of reasons, including the fact that they rely upon people coming for follow-up care, and they don't always continue in care long enough for you to measure the outcome.
Yep. Andy Ryan?
Yeah, so for those of you who couldn't hear, Andy was observing that the commercial ACO trend was extremely high, and even if you account for the fact that there were no non-users in the baseline, so that wouldn't solely explain the finding. And he asked why, and might it be related to the non-claim spending growth? It might be. We haven't broken it down, Andy, honestly, to try to figure out why the trend was so high for the commercial ACOs. But your supposition is, a fair basis for thinking that's at least part of it.
And do we have any sense of the impact from performing the age-sex adjustment and the truncation? Because something I've always not struggled with, but we've put this matter to bed that we're going to measure insurer and provider level performance on an adjusted basis to create some fairness in the calculation, to mitigate the risk that they were drawing incorrect inferences about performance. But the actual spending, the unadjusted spending, is the cost that society bears. So there is this broader question of what's the utility of measuring this. I think we should try to maybe dig into this question for next year, since I would like to better align the insurer and the provider lenses on this as well. Did we have Dr. Holman, did you have a question, or were you going to comment on a mental health measure? Okay, he was going to comment on a mental health measure. Any other questions about any of this data? Okay. Before we move on to the next part of our agenda, which I think we can do, we planned on, there's a potentiality that we could wrap up early today, since in the past we've done 3 panel discussions. We're only doing 2. And there may be a lot more Q&A in the next one, given some of our speakers. I do want to just put in a final plug, not for the chart book, but for the OHIC Data Hub. So there's this question of whether Rhode Islanders are traveling to other states to seek care. We're putting some data in the public domain in the inpatient space around that, as well as in the outpatient space in terms of a chemotherapy care migration analysis. So those tools are available to you on the OHIC website. You can see the amount of spend that is incurred for Rhode Island residents in Massachusetts and Connecticut by major diagnostic category. I think there are some interesting conclusions that you can draw when you dig into the specific major diagnostic categories, but that information is now available on the Data Hub. Okay. So with that, I think we can just transition, if the panel is ready, to the next section. All right. I'm going to hand it over to Rachel Block.
Hello, everybody. I'm a program officer with the Millbank Memorial Fund. I know because of Chris Kohler's ubiquitous presence in this community that all of you are quite familiar with Millbank, but very briefly, our general mission is to provide evidence and experience to state health policymakers to improve population health. And that is the context in which, starting about 10 years ago, we started to focus specifically on the question of how states might look systemically at growth in healthcare costs and the impact that that has on population health. As a result of that early work, we were very pleased to get financial support from the Peterson Center on Healthcare to launch what we call the Peterson Millbank Program for Sustainable Healthcare Costs. And the states that are participating in the panel today are all members of that particular program. And briefly, we started this program based on the initial experience of Massachusetts adopting a cost growth benchmark, and several states that then followed through either legislative or executive orders to do similar things. We felt there was an opportunity to share the experience of those states, and so this panel is really an outgrowth of that sort of work. The information that we share is kind of similar to the Q&A that we just had, asking about the data analysis and the experience in Rhode Island of looking at healthcare system performance. Some of the sharing is very highly technical information about data collection and analysis. And what we've been able to achieve is not standardization of those methods, but pretty consistent approaches. And so we're building towards not only for each individual state to be able to analyze their performance, as you heard today from Rhode Island, but also to be able to compare across the states. We're also sharing information about the policy actions that states are considering in response to both the overall cost growth information as well as the cost driver information. Again, the Cost Trends Steering Committee here in Rhode Island is a forum where those discussions have been taking place. And then finally, strategies for engaging stakeholders in the process. And this is really twofold. One is, how do you really build the case for responding to healthcare cost growth and making it more sustainable relative to the economy, relative to what households can afford, but also in terms of the actions that are necessary to actually address healthcare cost growth. So all three of those dimensions are things that we've been addressing through the Peterson-Milbank program for the last several years, and it is really a privilege to be able to work with leaders who are here on this panel today to share some of their experience, both individually and the experience they've had of working with each other. So very briefly, in terms of introductions, I know Cory doesn't really need an introduction. Recently, finally approved as the Health Insurance Commissioner for Rhode Island, serving for some time. Yes. Serving as acting Health Insurance Commissioner and Policy Director for OHIC prior to that. And of course, Rhode Island, in many of the activities of OHIC, has been an inspiration for other states that are interested in cost growth related work. David Seltz is the founding executive director for the Massachusetts Health Policy Commission, which I'm sure some of you have heard about. And the commission administers the cost growth benchmark program and a series of other health reform initiatives. And prior to this, David worked on the legislation that actually established the commission and its authorities. And as I noted, Massachusetts has really been our linchpin in terms of learning for other states how these cost growth benchmark or target programs work. And finally, Dr. Deidre Gifford is commissioner of the Connecticut Office of Health Strategy, a title just conferred last week. Prior to that, director of the Office of Health Strategy in Connecticut, which oversees the state's cost growth benchmark program, certificate of need, and other healthcare regulation activities. Dr. Gifford, of course, well known here in Rhode Island, and also previously served in the federal government. So we're going to start with some very general information from Massachusetts and Connecticut, and then get into some Q&A about how these programs have been operating. So David, would you share with us just a few highlights of the Massachusetts Cost Growth Benchmark Program?
Absolutely. Well, good morning, everyone. Thank you so much, Cory, for having me here. Governor McKee, everyone in this room. It is great to be in Rhode Island. Excuse me. It is great to be in Rhode Island. I always love to visit. I came down a day early yesterday and went to Goddard State Park, had a wonderful hike around, and I hope that we get out a little bit early, and someone give me a recommendation for a little seafood or clam shack that I can go to on my way out of town. It is really an honor to be here and to hear this great presentation and to be a part of this event, because I do think these events and these discussions and these questions are really fundamental to states' efforts to be able to moderate healthcare spending growth and to have these types of informed dialogues about how we improve the performance of our healthcare systems. So I'm David Seltz. I'm from Massachusetts. I've worked in health policy in Massachusetts for 20 years. And about 12 years ago in Massachusetts, our state legislature really took a comprehensive look at trying to wrestle with the concept of healthcare costs. In Massachusetts, we have an incredible healthcare system, world-class institutions, a thriving biotech and life sciences economy, but we also have a very expensive healthcare system. In 2009, we had the highest per-person healthcare costs of any state in the country, and the United States has the highest per-person healthcare costs of any country in the world. So in 2009, Massachusetts was the most expensive place on the planet for healthcare. And our legislature said, this is not sustainable for the future. And so the legislature came together and passed legislation that had at its center this idea of a healthcare cost growth benchmark. We call it a benchmark, you call it a target, but really it's fundamentally the same thing, about setting a measurable goal for moderating the growth in total healthcare expenditures in our state. Alongside setting that goal, the legislature also established a brand new, unique in the country, independent state agency called the Health Policy Commission. And this new state agency would be staffed by professional health policy experts that would help guide and monitor the state's efforts to meet that healthcare cost growth benchmark. And the Health Policy Commission is governed by and large by citizen experts. And I was the first executive director of the Health Policy Commission, established nearly 12 years ago. We have been at this for quite some time and have learned a lot of lessons along the way. And I hope in today's discussion I can share some of those lessons learned. In addition to what we do, very similar to OHIC in terms of moderating or analyzing and evaluating year-over-year growth, identifying, as we heard today, where are those areas of cost drivers, where are those areas of opportunity. We also have an all-payer claims database that we use to analyze those cost drivers. We have a couple of other important responsibilities that I want to quickly mention. We're also a partner to our healthcare industry. We have distributed nearly $100 million in grants, mainly to community hospitals and community providers, to help them innovate and test new ways of delivering care that meet that goal of being able to reduce spending growth while still improving quality and access. We're also a convener. Much like this event today, we also hold an annual cost trends hearing where we invite the senior leadership of our major health plans and health systems to testify each year about what they are doing to bring the state's healthcare spending underneath the benchmark. And finally, we're also a market monitor. We understand that the business of healthcare is rapidly changing, and the business of healthcare impacts cost, quality, access, and equity. And so we have a role in Massachusetts of monitoring and evaluating those significant changes of mergers and acquisitions, both of hospitals and physician groups, and evaluating what we think those changes will mean in terms of some of those different dynamics. And while we don't have the authority to block a certain transaction, we do have the ability to stop and pause a transaction while we conduct our review. And our reviews have been used by the Attorney General's Office and our Department of Public Health to impose conditions on transactions to ensure that they meet the values of the state. As I said, we've been at this for 12 years. We have 10 years of data with regard to our performance. We've had some years where we've gone above the benchmark. We've had some years where we've been below the benchmark. Overall, of the 12 years, about 11 years that we have data, we've been below the US kind of comparable rate of growth every year except one. And we think that that shows that there has been a moderation in our spending growth compared to that US average. And if you added up all of the difference between our spending growth and that US average growth, we're talking billions and billions of dollars in avoided spending for Massachusetts residents. And that goes to the heart of why these efforts are so important. Because even shaving a percentage point or percentage point and a half off of healthcare spending can have multiplier effects in terms of the amount of dollars that can be saved. However, in recent years, we're seeing that our healthcare spending growth is starting to accelerate, and it is concerning. You saw today that Rhode Island met your target for 2021 to 2022. Unfortunately, in Massachusetts, we did not. Our spending growth, total spending growth, was 5.8%. I think that's nearly 5 times the rate here in Rhode Island. And so we in Massachusetts and the Health Policy Commission, having learned from these last 12 years, are working with our legislature to promote and to advance another piece of legislation to evolve and modernize our approach for the next 12 years. And I hope to talk about some of our recommendations on that.
Thank you, David. Deidre, give us a quick overview of the Connecticut Office for Health Strategy, your responsibilities, and how those have evolved over the last few years.
Thank you, Rachel. Hello, everyone. I am so delighted to be here. I'm a little bit overwhelmed by the number of familiar faces. I wasn't anticipating this flood of memory to come over me when I entered the room. But I am honored and privileged to be here this morning to talk about the Connecticut experience and how we are working with our neighbors in Rhode Island and Massachusetts
around cost, quality, and primary care. So as Rachel mentioned, in Connecticut, we have an office that's called the Connecticut Office of Health Strategy. And it's a relatively new state agency, not independent like the MHPC, but a small state agency that is charged with the overall health policy and strategy for the state. We have a number of responsibilities within the Office of Health Strategy. Among them is our Healthcare Benchmark Initiative. In Connecticut, we look at not only cost trends, but we have separate targets for primary care spending, as you have been working on here in Rhode Island, and targets around quality as well. We are a new healthcare benchmark initiative in Connecticut, relatively speaking. The program was begun in 2020 by Governor Lamont's executive order, and then was put into statute in 2022. So we are just in our second year of reporting on our benchmark. We don't have the experience of Massachusetts and Rhode Island. And of course, our first year of reporting was growth between 2020 and 2021. So all bets were off in terms of, bounce back from the pandemic, the decline in growth in 20 and the rebound in 21. So we anticipate it'll be a few years before we have sort of a steady and more predictable way of measuring growth in Connecticut. So our office also does a number of other things around healthcare spending. When the legislature is interested in knowing something about what's going on in healthcare cost growth or quality, we don't have a CHIA in Connecticut, so our office is often given the responsibility of studying particular issues. For example, we're in the midst right now of studying pharmacy benefit managers and their impact on cost growth in our state and their role in some of the spending trends that we're seeing. We've just completed a study looking at behavioral health spending in our state, comparing Medicaid, commercial, and Medicare in an effort to understand whether we have appropriate rates and appropriate workforce around behavioral health care in our state. Like David and the MHPC, we also have the Certificate of Need program in our office and are involved in reviewing hospital transfers of ownership, as well as establishment of new facilities, radiology equipment, the usual Certificate of Need issues that also live in our office. So we are thrilled in Connecticut to be part of this growing number of states that are part of the Peterson-Milbank coalition. We've learned a tremendous amount from Rhode Island and Massachusetts in particular. Really, both states are leaders in these efforts. Our statutes, in many cases, are modeled off of those from other states, and we all look to one another for anything from as detailed as measurement methodology to as high level as consumer engagement, employer engagement, hospital engagement strategies, et cetera. So I'm very happy to be here this morning and look forward to conversation about our work in Connecticut.
So next we're going to focus a little bit on some of the specific actions that the states have taken to try to address their healthcare cost growth. And Cory, we're going to start with you. As we just discussed, Rhode Island met the cost growth target in 2022. What do you think are the factors that contributed to this, and what other collective actions can stakeholders in the state take together to try to continue to meet that target in the future?
Thank you, Rachel. So I will not summarize Michael Bailitt's presentation from about 45 minutes ago in depth, but as you can see from the numbers, we identified the reduction in hospital inpatient spending and professional physician spending, as well as the net costs of private health insurance, which were the three key leading drivers of our meeting the cost growth target in 2022. And over a 3-year period, we're below our cost growth target in terms of rate of growth. I want to take the answer to this question in a more forward-looking approach and actually talk about some of the recommendations that I've included in the annual report. So you can look at the annual report on the OHIC website, and we've identified 4 recommendations which we think are necessary to ensure that we meet our cost growth target over time. I think that there are increasing costs in the system. If you read reports about national for-profit health insurers' performances, talking to local payers, there is upward pressure. So we have to ensure that we have a workforce to care for patients in the lowest cost, most appropriate setting. And that's where we're investing in community-based providers like primary care providers, behavioral health providers, et cetera. So the first recommendation is to make those targeted investments. We have to be careful in this work of not inadvertently convincing people that our purpose is to reduce spending across the board in every category. We know that there are areas of our healthcare system that are under-resourced that need additional funding. I've said publicly many times, I'll say it again here, I think the state needs to address its primary care reimbursement rates. I think we need to increase total funding to primary care. That's not just a today issue where we have severe access issues, but it's a long-term perspective. We have to assure that we have the workforce over the long haul to provide for Rhode Islanders' care. The rate recommendations from the OHIC Medicaid rate review, those are pending before the General Assembly in the governor's fiscal year 2025 budget. Those should be implemented at least as planned on a 3-year time horizon, if not quicker. And those will support community-based providers, deliverers of home health, behavioral health, et cetera. I think we also need to think about approaches to facilitate and expand payment reform in a multi-payer manner. And so that's where we're looking to partnerships with the federal government to the degree possible to bring additional investment to the state for providers. The second recommendation is maintaining some of the work that we've done to date, and that is through regulation. We have price controls in the commercial market around hospital rate growth. I think those should be maintained, though I'm always happy to discuss with industry any changes to that structure. I think it's important for there to be a market guardrail on price growth. For next year's report, you can expect to see some additional analyses of consumer impact and affordability. An area that I think we need to focus on is the burden of out-of-pocket payments for consumers, in addition to the total spending. In Rhode Island over the last 20 years, the average family deductible has quadrupled. There's a reason for that: growing healthcare spending, driving premiums, and employers ultimately shifting more of that burden onto their employees, and that has a real impact. And then finally, an area where we can discuss a little bit later in the panel is where I'm inspired by our neighboring states, and that is, I think there are 2 sides to this coin. There's healthcare spending, and there's provider revenue. And those are 2 sides of the coin that you need to have equal visibility into. And so I think there are opportunities for Rhode Island as a state to invest in the capacity to systematically collect, analyze, interpret, and publicly report data on health spending or health financial performance by health systems and hospitals in particular. And other states have provided models for that. And finally, we have a very strong Hospital Conversions Act in this state. We have a strong regulator in the Attorney General's office and in the Department of Health. But there are areas of market oversight that I think we should evaluate, and that is the acquisition of physician practice groups. So currently, physician practice groups do not have to notify state government of ownership changes, and there's a lot of interest, I think, between hospital-based systems, private equity groups, and health insurers in acquiring physician practice groups. So we need to ensure that we have proper market oversight. Those are just 4 areas or sets of recommendations that we're making in this year's report, and I think if we act upon them, we'll be in a better place going forward to not only ensure that Rhode Island is meeting its cost growth target, but to ensure that we're making data-driven policy and having a data-driven discourse around healthcare in this state.
Thank you, Cory. David, one of the tools that the Massachusetts Health Policy Commission has is something called a performance improvement plan. And last year, the commission voted for the first time to issue a performance improvement plan to Mass General Brigham. Could you explain a little bit about how the performance improvement plans work? And more specifically, what are some of the specific actions that Mass General has taken and how the commission is evaluating the experience of working with that one particular performance improvement plan?
Yeah, absolutely. So the performance improvement plan process is one of our key accountability tools for the healthcare cost growth benchmark. So the benchmark, it's our statewide target, right? We evaluate that every year. But what about the performance of individual health systems and individual health plans? So we built into our law a process whereby every year our sister agency, which I should have mentioned at the outset, the Center for Health Information and Analysis, or CHIA, they're kind of like our data agency, sister partner agency. They will confidentially refer to us a list of all of the kind of health systems and health plans whose total medical expense growth exceeded the benchmark in that given year. And then we conduct a review of each of those individuals' performance. And we do that based on a multifactorial review. What was going on with that particular health system or health plan in that particular year? Where are their pricing levels? What patient populations do they serve? What have been their trends over time? Is there something going on in that specific year that maybe was outside of their control that explained why or why not their spending exceeded the benchmark? And ultimately, the board of the HPC makes a decision about whether or not we think that a performance improvement plan is warranted to help that organization bring their spending growth back underneath the benchmark. So we conduct these annual reviews. It happens confidentially, so it is a little bit of a black box. But as you mentioned, Rachel, in 2021, we approved for the first time our first performance improvement plan of Mass General Brigham. Mass General Brigham is our largest health system in Massachusetts, anchored by Mass General Hospital and Brigham and Women's Hospital. We required that they file a performance improvement plan with the Health Policy Commission based on our analysis of multiple years of over-benchmark spending growth. And I want to say a little bit about this performance improvement plan and maybe debunk some myths about this. The plan is an 18-month plan to try to bring their spending growth back in line with the benchmark. What this plan is not is about cutting their admin expenses. So if a health system came, if we said, Mass General Brigham, we'd like you to do a performance improvement plan, and they said, okay, we're going to lay off 2,000 people. That is not an acceptable performance improvement plan. That does nothing to actually bring the TME of your patients back in line with the benchmark. Because again, we're talking about the healthcare spending of their patients and the patients that use their system. If they said, well, okay, we're going to close down all of our outpatient behavioral health services, we would say that is not an acceptable plan. There's no way that closing down your outpatient behavioral health services is going to bring your TME growth down. So if you hear people who say that performance improvement plans are somehow going to cause people to lay off people or to close services, I'm here to tell you that that is not the case. Let me tell you what Mass General Brigham did. They said, okay, we're going to tackle some of the drivers of what is driving our spending for our patients. And what do we know drives spending? Use of care, site of care, and price of care. And they tackled all of these things in their performance improvement plan. They said use of care. All right, we're going to expand one of our care management programs that deals with our most complex patients. And we're going to expand that program to our commercial patients, and we're going to make this available to our commercial patients so they can avail themselves of this intense care management program that we know reduces unnecessary emergency department use, unnecessary hospitalizations, and improves the quality of care for these patients, and as a result, reduces unnecessary utilization and improves the care of those patients. That's going to be one of our strategies. Another one of our strategies, we looked at the data. We said, you know, Mass General Brigham, you use a lot of MRIs compared to some of your other systems. Great. We're going to put in place a clinical standards that we're going to roll out across our system to be able to say and work with our physicians to say, do we need an MRI in this case, or is there something else that we could do? Utilization. All right, site of care. They said, all right, we're working on this hospital at home program where we're going to be able to move patients out of the hospital and provide them hospital level care in the home. Now, as a part of this performance improvement plan, we're going to expand that program. And we're going to be able to get our board to sign off on this because it's part of this performance improvement plan. We're going to expand that. We're going to get more people out of the hospital into a home setting at a lower cost. A better place for those patients to receive care, out of the hospital, lower spending. And finally, price. We know that they're a high price provider. They know that they're a high price provider, and they worked with their commercial partners in their contracts to make commercial price concessions to say, all right, we're going to deal with some of our pricing and try to bring that a little bit more in line with others. So this is a $180 million savings plan that they implemented over 18 months. The 18 months just ended at the end of March. We have gotten their kind of quarterly reporting along the way. According to their quarterly reporting, they have met and likely exceeded that $180 million target. We are in the process of doing our own independent evaluation, and so we will have the final word about whether or not that is successful, and we will make that determination later this year. But I think this is a really instructive and a valuable tool in states' toolbox to have. One, even the process of doing the annual review has a sentinel effect because health systems and health plans know that the Health Policy Commission is watching and that we're going to be following up and asking questions. And even if we don't do a performance improvement plan every year, they know that we're going to follow up and ask those questions and those tough questions. And in those years where we do see that trend, it became an opportunity, not as a punishment, but as an opportunity to actually work together to implement those strategies that not only reduce spending, but in many cases improve the quality and access of care for the patients of that system. To me, that's a potential for a win-win, and I think that's a tool that many states should have in their toolbox.
And I just note that a nugget built into this whole model is that there's a consistent measure of spending that all of the plans and providers are familiar with and has been now used for many years. And so it's not like there's just 1 year to the next, there's some new thing we're going to do. The standard is consistent over a period of time, and everyone can build their models around that consistent expectation. Deidre, you mentioned one of the responsibilities of the Office of Health Strategy is the Certificate of Need program, and that has many different dimensions. Just recently, the state approved the acquisition in Connecticut of some hospitals from Prospect Medical Holdings. And could you say a little bit about how the Certificate of Need provisions are being used by Connecticut as a tool to help to address sustainable healthcare cost growth?
Thank you. Before I talk about CON and relationship to our work on the benchmark, I just want to emphasize something both Cory and David talked about, which is that the goal of all of this work is to help people afford their healthcare services. We recently, in 2022, we had a survey of Connecticut residents, and the results about their ability to afford their health care, and the results were very, very sobering. In Connecticut, one of the wealthiest states in the country, about a third of people reported that they were limiting their use of health care, avoiding the doctor, or not refilling medications, or cutting their medications in half because of affordability issues. And almost half of people said that they were generally concerned about their ability to afford their health care. So as we do this work, and we go into the weeds on both policy and data, I think the challenge for all of us that are doing this benchmark work is to think deliberately and explicitly about the ties between this work and the affordability of health care for people. Because even if we see our cost trends going down, what we have to make sure is that that translates into premium and out-of-pocket cost changes. And sometimes that last connection between the benchmarking work and the actual out-of-pocket cost for people on the ground is challenging. So I just wanted to put that as a frame for all of our work in Connecticut, and I hope that we have another one of those surveys next year. We're working on that. I think Rhode Island is currently in the midst of a similar survey. It's very grounding for people, for us, doing this work. With respect to the certificate of need and the link to affordability, that's obviously new in Connecticut since we just passed our benchmark statute a couple of years ago. But we have 13 criteria in statute when we do a certificate of need review, and one of them is how the proposal, the application, will impact, and our statute says, the cost effectiveness of health care in Connecticut. So as Rachel mentioned, when we engage in conversations with providers about approval of a certificate of need, one of the things, the tools that's now available to us is to say, can you demonstrate to us how this application will link to the cost growth in Connecticut? And in the certificate of need, the agreed settlement for the Yale New Haven Health purchase of the Prospect hospitals, there is a condition that ties to our cost growth benchmark explicitly and asks that the hospital constrain its price growth to the benchmark rate plus or minus 5%. It's interesting, and this is a little bit of a weedy issue, but I think very important for this audience to think about. Hospitals per se are not subject to the benchmark, right? Hospital systems with their attributed lives are. Hospital per se are not. So, that was a good exchange between the hospitals and our office talking about the relationship of the benchmark to actual hospital price growth. And so, we landed on this target of the benchmark plus or minus 5%, given that hospital costs alone are not the total of what's driving cost growth in the state. I also think that the transparency that David mentioned of this benchmark process is really transformational when it comes to the looking at healthcare cost and quality and primary care spending. These conversations don't necessarily happen in states that don't have these benchmark programs, and it has become the basis for conversations, not always pleasant ones, between the state and providers and insurers about cost growth. So we will, continue as our program matures in Connecticut to think about how the Certificate of Need program ties with the cost growth benchmark. We can't go beyond what's in our statutes, but clearly it's an opportunity as we talk to providers who are looking at expanding, buying, selling, limiting services to talk about the impact of that on cost.
So, David, you mentioned that you'd like to talk a little bit about the legislation that is being discussed in Massachusetts. Could you give us an overview and just talk a little bit about what you expect to happen?
Yeah, so as I mentioned, we've been made some recommendations this year to really evolve our approach based on lessons learned. I think two of our main priorities at the Health Policy Commission are continuing to embed the concepts of affordability and health equity into all of our work. As Deidre said, creating the linkage between these benchmark programs and THCE and TME and these big concepts of statewide spending, and then to how do people feel healthcare? How do they feel it in their deductibles? They feel it in their premiums. They feel it in lost wages. That's how people feel healthcare, and I think we need to figure out a way to make those connections stronger, where we're doing all of this hard work on the macro sense on healthcare spending. How do we make sure that that actually translates into relief? And so we've made recommendations around setting healthcare affordability benchmarks and a healthcare equity benchmark. Again, similar concept. We know that there's these longstanding disparities. We've always been inspired by Rhode Island, who has had affordability standards as part of OHIC's review for a long time. I don't know how many years.
About 12 now?
12 years. And we're really excited that there is a bill moving through our House of Representatives that not only includes the concept of having affordability standards in our insurance review process, but very excitingly establishes a new division of health insurance in Massachusetts. I like to call that DOHI. That's what I'm going with in terms of the acronym. But we think this new division of health insurance is really inspired by OHIC and the success that OHIC has had in Rhode Island. And so we are learning from our neighbors here, and we're excited to see that legislation continue to advance through the process. Another key part of this legislation that I am also excited to see move forward is an expansion of our market oversight rules, really to close some gaps around the increasing presence of private equity in healthcare. I mentioned before that we have a role in terms of reviewing and receiving notice of certain market transactions like mergers and acquisitions, affiliations and joint ventures, but there's some real gaps in that. And some of those gaps include the purchase of healthcare providers by private equity, or the significant sale of assets, such as real estate, by private equity or by the owners of healthcare institutions. We need to close at a minimum these transparency gaps to understand where, when, and how these owners and operators are making significant changes that we know will impact healthcare delivery in Massachusetts in the future. And there are a number of provisions in the bill on that front. So I'm excited to see it move forward.
I'd just like to mention that Baylor Health completed a report with funding from the Commonwealth Fund a couple of years ago, Michael, that described the insurance rate review process as one of the tools that could be used to address healthcare cost growth. And also some other states are now considering similar affordability standards and restructuring of their health insurance regulation system. So we're excited to see that idea launched in Rhode Island, starting to spread to other states. Deidre, you've had legislation passed, and I know you're working on some more legislation this year. Could you just describe a little bit of the specific things that you're focusing on, and what are some of the specific things you might be learning from Rhode Island's experience?
Yes, so our legislative session ended last Wednesday. So in Connecticut, we have a biennial budget, and so every other year is a compressed short session, which has a less extensive budget and fewer policy proposals. So this was a short session that just finished, and it was highly unusual. If anybody follows the news from Connecticut, there was actually not a revision to the biennial budget proposed. The biennial budget that was adopted in 2023 was left largely in place. So there was not a lot of opportunity for new programs or policy changes this year. But that didn't stop us from putting a number of them on the table, and as you say, Rachel, many of them inspired by Rhode Island and your work here. We did have a draft proposal of affordability standards that would have been a shared responsibility between our office at the Office of Health Strategy and our Connecticut Insurance Department. That did not go forward, but I think we'll continue to build on that concept. We do not have a separate Office of Health Insurance in our insurance department, and so the idea was to have the review happen at the Office of Health Strategy, and then advice given to the insurance department as they did their annual rate review. So we'll see how that plays out next year. We did have a proposal to implement performance improvement plans in Connecticut, as you heard David describe from Massachusetts. As we held our first benchmark hearing last year, and as we've met with insurers and other stakeholders, we heard a lot of the phrase, "We need more teeth in the benchmark." And then we also heard from providers, the benchmark is too new in Connecticut for us to put any teeth in it. So we're having this conversation about how we do our analyses, what kind of data we're using, what kind of metrics we're reporting, and getting used to that process and the back and forth, the colloquy that happens between the state and the entities that are subject to the benchmark, and then others who want to see us move ahead quickly, like our neighboring states of Rhode Island and Massachusetts. So we put the PIPs on the table this year with a penalty for only failing to engage in the PIP, not for not meeting your PIP benchmarks, but just failing to engage altogether. That also was not passed through the General Assembly. We had a number of proposals related to market oversight, mostly around transfers of ownership, as all of our states are experiencing challenges with particularly hospital changes in ownership. We put some enhanced oversight for transfers of assets, and also looking at multiple levels of ownership. Our statutes currently look at the most immediate owner of a facility or hospital when that transfers, but other owners that might be having functional or operational control, if they change, are not currently reviewed. So we put some proposals there on forward on enhanced oversight. Also not passed by the legislature. We did get some enhanced reporting of financial metrics so that the state can have an earlier insight into facilities or hospitals that may be really getting into serious financial difficulty, and the state may not find out about it until they're well into a challenging financial situation. I don't know if your states have more frequent reporting. In Connecticut, we have just annual reporting around hospital financial statistics, and people finding that going for a whole year before you hear about challenges could be, it could be helpful to have that information sooner in case intervention is required. We had some proposals around getting non-claims data into our all-payer claims database. You heard Michael and the team talk about measuring your non-claims data here. It's obviously an important part of the spending picture in Rhode Island. We were not successful in getting the non-claims data legislation passed. So we are, you can tell, we are looking to you as a model state for all of the ways that you have been able to tackle your benchmark and your transparency. And we'll be back at it again with our members of our General Assembly next year. As many of you know, these really kind of complex concepts that have lots of ripple implications through the healthcare system take a while for the community to get familiar with, to get comfortable with, and to really understand what your particular state wants to move forward with. It's very helpful to have, you know, this group of 3 states working side by side along with all the other states that Milbank has brought together. I think even at the federal level, they are looking to states as to how they are tackling these affordability challenges. And so I congratulate you in Rhode Island for really being at the cutting edge of this work and setting the pace for the rest of us.
So Cory, we've talked a lot about what other states are learning from you. Could you say a little bit about what are some of the things you've learned from the other states, and are there specific programs or policies or data analyses techniques that you'd like to borrow from other states?
Absolutely, Rachel. So let me just correct something I said earlier. We have had affordability standards for 15 years, not 12, but they have changed over time, and some have been sequenced in. So we've learned a lot from our peer states. As I said, we had affordability standards through the Office of the Health Insurance Commissioner. We had a lot of work going on in the market around payment reform, but we didn't have a cost growth benchmark program. We copied that idea from Massachusetts. I believe we were the third state to develop a cost growth benchmark after Delaware. And for me, I like to think of the benchmark as the unifying logic of our activity. So healthcare is really complicated. State government sure is complicated. And it's helpful to have key performance indicators and goals for the work you're doing, just a few goals. And the cost growth benchmark does that. So it helps us organize very neatly all of our activities towards meeting this end of bringing healthcare spending growth into line with the growth of the economy and wages. But we don't have to stop there. We can add to it quality and equity to create a more balanced perspective. I've been very impressed by much of the work that our peer states are doing around data. So a lot of the documentation that you've seen today in our annual report and our chart book, that's inspired by Massachusetts. Massachusetts does a superb job of collecting data and disseminating it, and it's an inspiration. I look at Health Policy Commission documents all the time for inspiration and probably commit a little bit of plagiarism, but I think that's okay. Yeah. Also, something that I think people should come away with is this type of work, it doesn't have to be unique to a specific type of state agency. So you have an insurance department, you have a sort of independent board type structured agency, and then you have the Office of Health Strategy, which is a really interesting concept within an ecosystem of state agencies doing the same type of work, working towards the same types of goals. Where I would like to continue to learn from our colleagues, not only in specific types of data analyses, which we've done. We've looked at some work that Connecticut is doing with its all-payer claims database to replicate in our analyses and our data hub. But I want to look at these other states and how they're measuring the financial performance and operating costs within the healthcare delivery system so that we can have a really good picture of what's going on. Dr. Gifford spoke to looking for the early warning signs of failure. I think we need to do that in order to have a more balanced perspective on oversight. So we have those metrics in place for insurance carriers. We don't have them for providers. That's an area that I think we can build on. We've talked about performance improvement plans. I think we're not quite there yet in terms of we're going to keep working with our steering committee and working through some of the existing regulatory mechanisms at the Office of the Health Insurance Commissioner to drive affordability, but I am going to be really interested in seeing the final kind of disposition of the Mass General Brigham performance improvement plan. And to the extent that your states can create greater affordability, as we're trying to do in Rhode Island, I think our citizens will be collectively better off. So again, the states that we have on the panel have been an inspiration, but there are states across the country working on this. I forget what the figure is, but with the inclusion of California, somewhere close to 1/5 of Americans are living in a state with a cost growth benchmark. So that's really inspiring that that has been built over the last few years.
So before we turn to the audience, I'd like you probably already have started thinking about some questions, and it's a real treat to have these folks here in person. Usually we just get to see each other virtually through our monthly Zoom calls and other kinds of virtual events. So please take advantage of the fact that we have these folks here in person today. But you've all touched on the link between affordability and equity. And while it's not a formal focus for the Peterson-Milbank program, we have collected information. The Baylor Health team produced a short blog for us a couple of years ago, looking at some of the things that states are doing to better measure health equity. I'm just going to go down the row here, and DJ, start with you. Just mention a couple of specific ways in which you see the connection between efforts to improve healthcare affordability and efforts to improve equity.
Thank you, Rachel. And I was really inspired by looking at Rhode Island's approach to public health and equity measures, and I think that that's something that we want to take back to Connecticut and expand our quality data. So in the survey that I mentioned, the Value Hub survey in Connecticut in the summer of 2022, the affordability challenges disproportionately impact individuals in Connecticut, people of color and people with disabilities. So those living in potentially medically underserved areas and people with complex medical conditions are disproportionately impacted by the issues that we're talking about today. So I view this work on affordability as really also significantly addressing equity. We know that medical debt disproportionately impacts individuals of color, and I think that this effort needs to keep in mind that as we make that link between lowering the cost growth trends while maintaining quality, that we need to keep our focus on the fact that not everybody experiences these issues equally. So we are not at the stage yet in Connecticut. We just are putting out our very first quality report this year, thanks to our friends at Baylor who've been helping us. We're not at the stage yet where we're able to really focus in on subsets of our measures, but that's certainly something that I think needs to continue to be a focus and something that we continue to talk about with peer states and learn from one another about how to use this process to really make an impact on the equity and access.
In Massachusetts, we've also done very similar type of consumer surveys around affordability challenges and found the exact same results that was mentioned here, disproportionately impacting Black and Hispanic residents in Massachusetts, and then following that through, disproportionately not getting the care they need due to the cost of care, and then ultimately disproportionately ending up in an emergency department for an avoidable condition. We have a couple of challenges on this front. Our data assets are still quite unreliable on some of these fronts. So we have an APCD that has unreliable race and ethnicity data in it. And so that's one of our main data assets. If we can't measure something, it's going to be really hard to improve it. So we have to make sure that our data assets are improving. But I don't think we need to wait for our data assets to improve to know that there are significant disparities and inequities, and we need to act now. Our state leadership, through our Secretary of Health and Human Services, is putting together an Advancing Health Equity of Massachusetts effort. We're really focusing on two areas, maternal health and cardiometabolic disease. We are using the data and public health data to identify those communities with the highest disparities and inequities, and really harnessing all parts of health and human services to really align efforts to really make a difference. We have, as I mentioned before, recommended that we at a statewide level should have something like a health equity benchmark. I think we have always felt that that shouldn't be the Health Policy Commission to decide what that is, that really should be a community and government conversation around where we set those goals. But I was really also inspired by Grace's presentation and just being able to say, let's set some baselines and report on them year after year, and let's set some reasonable targets for the future. And I think just like the cost growth benchmark, that alone can drive a conversation. And so I think there's a lot of space where we can move forward, even as we're needing to improve on data and other things.
Yeah, so a statistic I want to read to all of you is 2022 statistic, but it was in last year's report. And so this is 2022, so the data we just saw where Rhode Island met the cost growth benchmark, great result. But during that year, 15% of Rhode Island households reported having problems paying medical bills. And 24% of Black Rhode Island households reported problems paying medical bills. And that finding was statistically significant. So there is a difference between the Black population and the Rhode Island population generally. And that data comes from HealthSource Rhode Island's biennial health information survey, which is one of the best sources of information for Rhode Islanders. I see my colleagues here today from HealthSource. And that's something we should be aware of, and we want to track that over time. I want to give the Cost Trend Steering Committee a tremendous amount of credit. The steering committee does not exist by law, and the decisions it makes are not codified in law. These are voluntary, compact-driven decisions that you all make, commitments to goals. And during the 2022 discussions renegotiating the terms of our compact, where we established the cost growth benchmark values, the steering committee wanted to establish a concurrent set of public health and health equity improvement targets, having previously discussed adding quality to the benchmarking process. So these measures that were presented to you by Grace exist because of your voluntary agreement. And as Grace mentioned, we're going to be convening a working group to try to develop some actionable strategies to achieve these equity targets. But I really just want to applaud the members of the Cost Trend Steering Committee. You are a credit to healthcare in Rhode Island for the work that you do collaboratively. So thank you.
Just before we turn to the audience, you've each said both directly and implicitly that this isn't an issue or a solution that the state solely owns. It is something that the community needs to be actively engaged in. And I'd just like you, for any of you, to speak to what are some of the strengths of community engagement that you've been able to implement, and what are some of the challenges, what are some of the lessons, and how we can get more active community engagement in these discussions. If anybody would like to jump on that.
Well, to state the obvious, there are lots of different interests in these conversations and lots of different viewpoints, and all of them are valid and important, and getting to consensus from the various different stakeholders is the challenge of this work that I know you all have faced. I think it is because of the complex nature, the very detailed nature of this work, it can be challenging for us as policymakers to try to translate that into something that's relatable to community members and engage them in our work. I think that's one of the things that's on our strategic plan for this year in Connecticut, is to really think more about how we talk about our work to members of the community, non-provider, non-insurer members of the community who really feel this in their pocketbooks and in their day-to-day lives, but don't necessarily get the importance of all of this detailed work to those issues. So, our stakeholder group in Connecticut, also a voluntary group, has community members. The conversations tend to be a little imbalanced, with providers maybe talking more than the community members because of the technical nature of some of the conversations. So for us in Connecticut, I'll say it's a high priority and something that we continue to think about how to do better. We look to your stakeholder process in Rhode Island as really a model. You have a long history here in Rhode Island of getting people around the table, and I think that's what it takes, is that trust building and that open conversation.
I think on the issues of cost containment, as was just said, it's hard. These are complex topics. What we did at our last cost trends hearing is we, for the first panel of the day, and this is a hearing that's made up of the CEOs of all our health systems and health plans, but the first panel of the day, we invited community members to talk about how they experience healthcare. And they talked about having to make decisions between filling a prescription and paying their heating bill. They talked about having to split their prescription with someone in their household. And that is not the same type of conversation as TME and THCE, but it imparts a level of urgency about this work. and it puts a human face on why we are doing this. So it is hard to make the connection between the policy and the public, but it is worth it and it is necessary.
Yeah, I don't have much to add beyond what David and Dr. Gifford said. I think from my perspective as the health insurance commissioner, there's an additional level of translation of what are the implications for a cost growth benchmark and your premium. So speaking to an employer audience, how the two relate. But again, I think we need to do a better job of boiling this down and trying to put it into the real human terms. The same survey that I quoted to you about the percentage of households in Rhode Island who reported problems paying medical bills, that question goes a bit deeper, and it asks them, have you had to give up on basic necessities like food or rent to pay for a medical bill? Have you incurred increased credit card debt? Have you filed for bankruptcy? And we find in the surveys that there are Rhode Islanders that experience that level of deprivation due to healthcare costs. That's why affordability is a key concern of the Office of the Health Insurance Commissioner. It's one of the motivating factors behind the decisions that we make at the agency. So I don't have anything else to add beyond that.
Well, thank you so much. Now we turn to you. What are your questions or comments? What are some additional things you would like to learn now that we have these three states here together? Ira?
Thank you for a great presentation. We've talked a lot about changes over time, but we haven't really focused as much on baseline levels. That is to say, the differences in cost between the states. And I wanted to take this opportunity and ask a question that relates to a threat that I think exists to the sort of success we've had in keeping total costs lower in Rhode Island, and that is providers and provider movement. And we hear a lot from providers in Rhode Island that the reimbursement's too low, and that we'll just move to Massachusetts and make more money. And I teach my freshmen at Brown that every dollar saved is a dollar that's lost by some provider in the healthcare system. And this is very obvious. So I just wanted to see how the three of you think about whether providers actually do move. Is this a real threat that providers will leave Rhode Island because of the greener pastures and higher reimbursement and higher salaries in those other states? And it's not even clear that higher reimbursement means higher salaries, and those are the kind of data that are very hard to get. But I wanted you to comment on this sort of threat we're constantly under here in Rhode Island that actually might prevent us from staying at the 1.5 or below the 3.2 over time.
So I'll take a shot at answering that one. We certainly hear from providers that providers are leaving the state or that we're not able to recruit providers, but I haven't been presented with the actual data on that. So during the last 12 months, during the last 24 months, how many providers who, and let's talk about physicians for instance, there are lots of different types of healthcare professionals, but how many physicians who had been previously practicing in Rhode Island have moved to take employment with a Massachusetts or Connecticut or other state health system? How many have moved their practice? I haven't seen that specific data. One data point I have seen, and it came up at a recent committee hearing, was the AAMC provides data on in-state retention of physician trainees and what percentage then go out of state. And Rhode Island is towards the bottom of the list in terms of in-state retention. And the state with the next worst retention, if my view of the data is correct, is Connecticut. Again, there's not a lot of consistently assembled data on that for me to come up with a really numerical or data-driven answer. But I'm wondering if David or Deidre, if you have that.
Yeah, unfortunately, my answer is also a lot of anecdotal, like what I hear on the street. And I think it's a lot, even among physicians, are we talking about primary care physicians? Because those dynamics can be very different than some of the specialty physicians. And as you said, does higher reimbursement necessarily translate into higher salaries. We have a lot of academic medical centers in Massachusetts, and there are other reasons why physicians may be attracted to those positions, whether they want to have some part of their time in research, whether the prestige of the AAMC name actually has its own value detached from a salary. And we hear even within our state that there is, competition for certain, subspecialties that are particularly high margin. I think, across state lines, I guess the point I would say is, like, I accept the premise of the question, which is we should all be thinking about it, but I don't know which direction it all goes. And I know that there are people leaving Massachusetts because Massachusetts is really expensive to live in. And it's the housing costs, and it's the transportation costs, and the childcare costs that are driving people out of Massachusetts. We have an out-migration problem. So how does that play into these dynamics?
So I'm glad to be last on this one, and I will just say that only Rhode Island has Goddard State Park, and which is an asset. We hear the same thing, Ira, in Connecticut. Providers are telling us, the grass is greener elsewhere. And I agree with Cory and David that it's a very complex question, and there are many factors that play into where providers want to, locate and have their practices. I do think that the characteristics of the system overall, we read a lot about, it was in the Globe over the weekend, about provider satisfaction and the type of environment that they're working in, and doctors unionizing because of some of the issues, or wanting to unionize because some of the issues that they're facing in their practices. So those issues obviously play a big role as well in where physicians want to practice and locate. So I don't think salary is as David said, the only factor. What I would say to those of you in the world of health services research is that one of the things I grapple with, and I know others do, is how to appropriately benchmark all of these things. The lack of transparency in things like physician salary and things like a payment per service. We're better off now than we were 5 or 10 years ago with respect to transparency because of some of the leadership of many of our states, but we still really struggle to compare one state to another and to know what is the appropriate level for a lot of these metrics. Is $10,000 the right price? Is $5,000 the right price? You can look across the country, and the variation in some of these metrics is so extreme that it's very difficult to know what's the right payment or price or cost for any number of things in healthcare. So, I think the next frontier of a lot of this work, and I think Mr. Charbonneau mentioned the SAGE transparency and the work that's been led by Indiana and Rand, and now NASHB is putting a lot of these things out in the public so that we can once and for all compare to a standardized benchmark, state to state, system to system, hospital to hospital. But that is really, I think, where the country needs to go in terms of figuring out what is the appropriate level of payment for a lot of this work.
I'll just mention, many of you know Milbank last year published the first Health of Primary Care scorecard for the nation, and where we published, to the extent that it's available, state-level information on a series of metrics about what's going on in primary care. And I'll just say two things. One is the story is not good. The health of primary care in the United States and in most of the states is poor. But the other is our utter frustration working with leading national health services research groups at the lack of the kind of data that we really need to answer the kinds of questions that we all have. So I just wanted to pile on to the, we need more data on these issues. We'll just also mention California, as part of their landmark legislation, has a very extensive set of data collection that they'll be doing around healthcare workforce issues, and we'll be very interested to see how that goes. Elena, did you have a question or comment?
I do. Thank you. Thank you for a great presentation. I'm curious, in Massachusetts and Connecticut, I won't put Cory on the spot, but can you talk about how you think about Medicaid in terms of your approach to the benchmarks and other regulatory, and then also the contributions and costs?
Elena. So it's a really important question, and one that we engage with almost on a daily basis, particularly with our hospitals, because they have concerns about the level of payment and whether that is a contributor to the commercial cost growth, so the cost shift question. So the way we have approached it to date in Connecticut, obviously we measure by market. So you saw Michael's presentation about cost growth by market, and we do the same. And our cost growth in Connecticut in Medicaid has been much, much, much slower than in the commercial market. We do not have Medicaid managed care in our state, so we set the rates at the state level. And like in many states, that's a complex process that involves the legislature and the providers, et cetera, et cetera. I think we need to continue to talk about this issue of the cost shift, because we do not have consensus about that between the data and the providers on the ground. Our hospitals in particular feel very strongly that that is a large contributor to the commercial cost growth, and the data suggests that it may not be. So I think we have to continue to shine a light, look deeper into the relationship between Medicaid payment levels and commercial cost growth, and continue to have the conversation. That's about the best I can do.
We take a similar approach. We look at all the different market segments, and I think that is the right approach, because we do need to understand when there are shifts in enrollment, how does that impact the total spend. We certainly saw this in some of our data where we had lower commercial enrollment and higher Medicaid enrollment during this time period, and then as I'll probably see in the next year's data, that Medicaid enrollment's going to come down with the redetermination, some of that commercial enrollment. So we need to be able to see the total pie and the total picture to be able to contextualize the changes in each of the different segments. That being said, I think we do have a greater focus on the commercial market, because we see that is the place where we have the strongest ability to have an influence. We work with our Medicaid program quite closely. We have a very strong Medicaid ACO program that has been quite effective in kind of managing total spend. But as we think about the balance of these things, our Medicaid spending growth has been quite low, and has been a reason in some years that we've been able to hit the statewide benchmark. And so I think it's take the whole picture approach, understand the dynamics that impact the changes between the different market segments, and then identify those areas where you can make a difference. I think there are, on utilization, there are things that we can do that cut across all the different market segments. And I'll just say, in Massachusetts, we rank very highly on some performance measures. On one measure in particular, we rank very poorly, which is avoidable hospital utilization. We rank 44th out of 50 states on avoidable hospital utilization. And I suspect that cuts across the board between Medicaid, Medicare, and commercial. So if we were able to do anything to try to do better on avoidable hospital utilization, that includes readmissions, that could have benefits across the board.
I might just chime in a bit, Rachel. In Rhode Island, we've been making some investments through our Medicaid program, not only in what the governor mentioned around the hospital state-directed payment, but previous years, adding to the rates for providers who care for Rhode Islanders with developmental disabilities, early intervention. There are some pending rate increases that are in the budget, which once fully implemented would increase spending estimated about $200 million. And so that type of cost growth will show up in our benchmarking, but we can contextualize that. So if in a given year, for instance, we exceed our cost growth benchmark because we've made necessary investments in the Medicaid program, that's something that can be appropriately contextualized. And we do focus very heavily on commercial. The materials you've seen today largely are commercial, because that's where we have these issues of private market forces working in a way that doesn't generate the optimal outcome for consumers.
I would also add pharmacy, I think, is another area where if
true.
states can do anything on pharmacy, that can have a benefit on both the Medicaid and commercial markets.
Any more questions or comments? Got two, I'm sorry, Al, right behind you, and then I'll come back to you.
My name's Teresa Carnegie. I'm the president of the Hospital Association. Thank you as well for the presentation. David, I am concerned about you being so excited about affordability standards, but we'll talk about that later. My question is, I am a little disappointed that I haven't heard any of you talk about administrative efficiencies. Denials of claims is a cost factor for hospitals, something that's being looked at the federal level. The generals looked at the number of claims denied. American Hospital Association is looking to quantify payer behavior in terms of cost to providers. So my inquiry is, are you in Mass and Connecticut taking any initiatives? Cory has initiated administrative simplification, but his authority to date is limited to asking, to a certain extent, some of the insurers to do some things. Broad question. That is a very important issue, I think, to all providers.
I'll start, and sorry to disappoint, because this is really an important issue, and one of our main policy recommendations in our report is around administrative waste and duplication in our system. And we've quantified this in Massachusetts, and we're talking billions of dollars of just spending that we think provides absolutely no value to patients, providers, to the system. And we've made recommendations around standardizing prior authorization, utilization management, a number of these tools. These are recommendations that, not surprisingly, are generally not supported by the health plans. We have had voluntary efforts throughout the years where we've tried to bring people to the table to kind of voluntarily agree and agree to compacts. I think despite the very best efforts of many really dedicated people, those efforts have been very slow and have not moved at a pace that I think they need to. So we've made recommendations to have legislation that we need to really accelerate this. One of the recommendations that we think is really low-hanging fruit and that every health plan should be able to immediately agree to is around the automation of prior authorization. There's a new federal rule that requires automation of prior authorization for basically Medicare Advantage and Medicaid plans and certain exchange plans by, I think, 2027. This is going to have a huge benefit. It's going to be a huge lift for providers, a huge lift for health plans, but at the end of the day will really result in hopefully a much more seamless experience for both sides. Why don't we do this on the commercial side as well and do this all in a synchronous way? We wanted to set up a technical assistance to be able to help providers, those smaller providers that may need that help in terms of transitioning to automated prior auth. And let's just move there. Let's use technology where we can to be able to reduce this, and let's have standardized rules where we can. I'm more of a mindset of health plans compete on the quality, compete on customer service, compete on networks, compete on many things, but competing on having different prior authorization rules for the exact same types of clinical services, I don't understand.
Thank you for the question. It's also been a topic of conversation in Connecticut. And in fact, before this past session started, we did convene a co-chaired by our hospital association and our insurers advisory panel to try to work together, because people did feel that we disagree on so many things about how to tackle cost growth in healthcare, but this was something where there was a fair amount of agreement, and might be a place where we could do some trust building. That's been on hiatus during the session, so I look forward to that group, getting started and trying to produce some results. In the interim, though, our legislature has taken this up in Connecticut. I can't tell you actually in the flurry of last-minute bills last week whether things passed or not, but there were proposals around gold carding. So if a provider has, a record of most of their prior auths being approved, then they would get some sort of a pass. And something about peer review. Providers were very concerned about peer review not really being a peer review, and we're asking health insurers to engage many more specialists to do the peer review of prior auth. We hear from our insurers, of course, that this is just going to raise the cost of healthcare. So we continue with the back and forth, but we're also trying to grapple with those issues.
Cory's going to get the last word, but Al, do you want the second to last word?
Sure. I guess my question, I'll start with David, but Dr. Gifford, please. I think I know where Cory stands on this, but given that you've been wrestling to the level with hospitals specifically, given that you've been wrestling to the level of having performance plans and that sort of stuff, has that given you any thought to payment reform? I know that my interpretation of what CMS is doing is that they're eventually going to throw in the towel on the DRG system and go in another direction. I think the AHEAD program is, that's one indication of that program. So I'm wondering, where do you stand on payment reform?
So this was a central principle of our law when it was passed, was really moving off of the fee-for-service system onto value-based payment, alternative payment methodologies. And Massachusetts, I think, was ahead of the game really in terms of a number of states, in terms of our commercial plans, really moving forward on this. Unfortunately, we have seen that effort really stall out at the state level in Massachusetts, especially on the commercial side. We have great uptake in our Medicaid program. As I said, we run an ACO program in partnership with the federal government. We've kind of leveled off in terms of our Medicare lives that are under either, in any one of the different CMS models. And our commercial lives have really leveled off at about 40%, and that hasn't shifted in I would say, probably the last 6 years. And so as I, go and talk to different people, I think it's left our provider systems and health systems in that uncanny valley of between an old system and a new system, and not being able to fully shift over into the commitment towards kind of really buying into a value-based healthcare system and making all those investments, shifting away from all the incentives in the prior system, and still really chasing fee-for-service, chasing the high specialty care, while at the same time still experimenting and still trying to do these different population health programs. I don't know where it tips, if it will tip to one side or the other in the future, but I think there was a lot of promise, I think, 12 years ago, and as I sit here today, I feel that effort has stalled a little bit.
Yeah, I agree with everything David said, and we are in Connecticut less far along than you are in Rhode Island or in Massachusetts in terms of the percent of the spend or the covered lives that are in an alternative payment model. We're about to release our first report in Connecticut on the penetration of alternative payment models, but we know anecdotally that we have been lagging behind in our state. I think because of the reasons David cited, and because we have not really seen any modulation or the kind of modulation in trend that we hoped to see from these APMs, I think there's a fair amount of skepticism among many about jumping in with both feet. I know I hear it in my role. Show me the data that moving to X, Y, or Z model is going to have the impact that you say, and tell me why this isn't just another version of 1980s managed care. And so I think we all collectively have work to do. Those providers who have worked in a high-functioning alternative payment model, where, to Al's point, the majority of the payers are aligned, and that's the key. Those providers that have worked in such a system know the value. They know the value to their patients. They know the value to their, burnout factor as providers, working in team-based care, really being able to deal with chronic disease, really having time to engage with patients in the way that providers were trained to do. But it seems that the examples of that we don't have enough of those types of examples. And one person's opinion is because of the exact reason David described, is we are just dabbling in it, and in a lot of ways. And a provider needs to have all of their sources of revenue driving in the same direction in order to really be able to transform their model of care. And we just don't have enough examples of that. And maybe ahead, if we can get enough commercial payers involved in the global payment and the enhanced primary care payment, and that's the big if, we can get enough commercial payers to want to align with that model, then maybe we'll start to, we'll see an example.
And it's certainly not the only way to do it, but it seems that states have a great opportunity, one could argue responsibility, to be the convener to help to address those discussions. And of course, we know in Rhode Island that has been going on for some time. Before I turn it over to Cory to wrap up, please join me in thanking the panel for being here today.
Okay, and thank you, Rachel, for moderating the panel, and let me extend my personal thanks to Dr. Gifford and David for making the drive down and the drive over to Rhode Island for this event. This has been the most well-attended of the public forums that the office has hosted. I see a lot of familiar faces as well as some unfamiliar ones. That's a good thing. I saved a few thank yous for the ending. I want to thank Friedman Healthcare and Baylett Health Purchasing, which are the consultants working with us on this project. Without their assistance, none of this would be possible. I specifically, in addition to thanking Michael and Grace, I want to thank Jessica Marr, who is here in the front. Jessica has been my go-to person for all of this, the final reports, the analysis on the cost growth target. So let's give all of the consultants, including Jessica, a round of applause. Okay, so as you can see, we're really committed to this work, and I think by your attendance and engagement with us this morning, you are as well. So we look forward to continuing to work with you all, and in the minutes that we have remaining, feel free to talk and network, and we'll see you next year. Thank you. Thank you so much.
Congratulations. Good event.
Yeah. I watched some of your event from earlier this year. You have this big round.
We're at the legislature. Yeah, we can't afford hotel.
Yeah.